Hello, everyone. Welcome to 2022 and the compliments of the season to all of you. May it be less COVID involved and may we all have an enjoyable time. So today is an endoscopy gecko, and once again we must thank New Mexico and India for hosting us through their platform. Today we have in fact 75 people who have registered. I think there's about 25 or 30 on the call just now. That's very good news. And we've got, again, the usual culprits from Cameroon right through to Zambia, Uganda, Tunisia, Mozambique. So we've got a truly representative audience, and I hope you enjoy what we're going to give you today. First up is going to be Adam Boutall, and he's the head of colorectal surgery here at Cape Town, and he has an interest in teaching colonoscopy and is one of our sort of advanced polypectomists. Maybe he's the only one in the department, but there might be a few other claim that title. But and so as a result of that, he's volunteered willingly to give us a talk on the ABC of polypectomy and how to avoid complications. Adam, over to you, and we look forward to your talk. Please remember to post any questions you've got in the chat box, and Ed Jonas, who's co-chairing it with me, will help me handle the questions. Hopefully you have a few, and hopefully this is practical. Over to you, Adam.
Thanks very much, Sandy. I'm just going to go into full screen mode, which takes a couple of minutes normally. Sandy, if you can perhaps tell me when the screen is showing there on that side.
I'll do that.
There's a bit of a delay. I think the first thing to say about, I was asked to talk about avoiding complications of colonoscopy.
That's okay now.
Really the first thing. Great, thank you. So I think the first thing to say, before one can avoid complications of colonoscopy and to manage the complications, I think you've essentially got to know what polyps to take off, what polyps not to take off, and then how to do it properly. And then we can talk about some of the interventions that you can do when you run into a little bit of trouble. So that's really what I'm going to do to start off with. And I think the first thing that we need to discuss is, does this need to be removed? I've got a couple of slides here. We'll just go through them slowly. So the first one over here, we look at the picture, you can see this slide. And if you come across this, do you need to take it off? Clearly a polypoid type lesion, but is it actually a polyp? And what this is and what we're looking at is an inflammatory polyp as a result of someone who's had long-standing ulcerative colitis, which is currently quiescent, but has had major inflammation in the colon. And these do not need to be removed, those throughout the entire colon. And if you're uncertain of what to do, you could, with them, you can certainly biopsy them just to confirm that they are inflammatory polyps. You could it's a poor picture of this because I've pulled it off the internet. I don't have a picture of my own. But if you see a large submucosal nodule like this, and you take your biopsy forceps and push into it, and you get it's clearly a soft structure. So that's called the pillow sign, when your biopsy pushes into it and makes a dent. And that's usually a submucosal lipoma, and you can leave those alone entirely. In fact, if you do remove them, you'll probably create a perforation. Over here, we have multiple small hyperplastic polyps, typically occurring in the rectum. And if you have a hyperplastic polyp that's in the rectum or sigmoid, less than 5 millimeters, there's clear guidance that you can leave them alone. Anywhere else where you get a hyperplastic polyp, however, that needs to be removed because it could be a serrated adenoma. If you retroflex like you should do at every colonoscopy, and you see a polyp like this is a fibroepithelial polyp arising from the dentate line. It's usually in someone who's got hemorrhoids and there's prolapse of hemorrhoids in and out, and they develop this sort of irritative polyp. And unless it's causing the patient symptoms, you can completely ignore it. this lesion over here is another hyperplastic polyp. And, there you can go and look in your own time. If you look at the Kudo classification, you can see how to recognize them. It becomes very easy after a while to recognize hyperplastic polyps. But if you're not certain, if ever you're in doubt, remove them, write on your note, I think on your pathology report, I think this is a hyperplastic polyp. You'll get the report back. And if you're correct, you'll soon learn to trust your judgment about that. Remember, that's only in the rectum and the sigmoid that you can leave the less than 5 millimeter polyp. And then clearly what one needs is a very clean colon so that one can see subtle lesions like this big lesion over here that I'm sure you can all see. Hopefully it projects well enough. And that is a lesion that definitely does need to be removed. It's on the right side of the colon, ascending colon. It's flat. And these lesions, if left alone, have a high chance of malignancy and are usually following a mismatch repair gene pathway. So these are the lesions that are difficult to see. Most people can see the big pedunculated polyp, but these lesions can be quite subtle. They often attract mucus on top of them, have mucus on top of them, which attracts a little bit of muck and stool, that's residual stool. So if you don't have a perfect prep, you're going to miss these lesions, specifically on the right side. And when we're talking about a perfect prep, the only way to have the prep on the right side perfect is if you split your prep and give it, if you're doing a morning scope list, some prep in the evening and some prep in the morning. And if you're doing an afternoon scope list, you can probably give all your prep in the morning. So just in summary of what lumps don't need to be removed: lipomas don't need to be removed, inflammatory pseudopolyps, fibroepithelial polyps, and diminutive hyperplastic polyps in the rectosigmoid junction. So if you get a polyp that is in the colon that you think, and it looks like an adenomatous polyp or serrated adenoma, which does need to be removed, you need to have a couple of questions. The first thing you need to do is, what else is going on in the colon? Because it is pointless looking at a 1 centimeter or 2 centimeter polyp in the ascending colon, which is going to be a difficult removal in a thin-walled ascending colon, and actually you get into the cecum and you find that there's a cancer there and the whole right colon is going to go anyway. So you always need to know what's going on in the whole colon before you decide exactly what you're going to do. Saying that, sometimes if you see a small polyp as you're going in, it's probably better to take it on the way in because you might not find it on the way out. You also need to know, does the patient have a syndrome? Because if this patient has FAP, you might not be wanting to take out every single polyp. You might only be taking out the bigger polyps. If it's Poitiers disease, you just want to take out polyps bigger than 2 centimeters to stop intussusception, and that's largely in the small bowel. The actual hamartomatous polyps in Poitiers the malignancy doesn't originate from the hamartomatous polyps, although they are at increased risk. And you need to know, what is the disease process? Is there ulcerative colitis? In which case, just proving dysplasia might be enough to send the patient for colectomy, and removing all polyps in all patients with ulcerative colitis might not be necessary. The next question you need to ask yourself is, can it be removed endoscopically? So the first thing you need to know is if it's a cancer, you're not going to remove it endoscopically. There's certainly not many people doing ESD in South Africa, and the role for it is very limited to superficial submucosal invasion. So you're going to use your Kudo classification, NICE classification in Paris, and you can look those up in due course. They're all nice pictures you can get on the internet showing the classifications, and you can print them out and put them in your scope room. Is it safe? Are you going to be able to safely remove this? And we'll come back to that. Can I get it all out? Am I the person to do this? If you can't get all of the polyp out now, you probably shouldn't do it, because your best chance of taking a polyp out is the first time. It only gets more difficult after that. So sending it to someone else after you've had 3 goes is making it an impossible task for them. So rather send it to them up front. And then how should you get it out? You need to have a strategy. Are you going to do advanced procedures, or is this just a simple polyp? Is it a stalked polyp? And we'll get into that a little bit later. Most importantly, is it safe? So the safer places to do polypectomy is in the rectum. The rectum is covered on lower down, specifically on all sides, and so perforation is extremely difficult. If you can lift a polyp, it's generally safe and your chance of perforation is small. And the smaller the lesion, the lower the chance of complications, be that bleeding or perforation. You need to be careful if a lesion doesn't lift nicely, because that means it's either a cancer or it's been tethered to the submucosa by previous fibrosis, and your chance of perforation gets higher. A redo causes fibrosis, increases your risk of perforation. The larger it is, increases your risk of perforation. On the right side of the colon is thinner, and therefore the risk of perforation is greater, and right-sided lesions have a greater chance of bleeding. And around the ileocecal valve, because you often get prolapse there, you can take off what you think is a superficial snaring and you're actually doing a full thickness snaring. You also need to know what backup do you have. If you're a medical gastroenterologist, is there a surgeon that's going to be able to help you? If you're a surgeon, is there theatre around? Are you scoping in your rooms? Is this something that would be better done in theatre with a team on standby? And all these things need to be decided before you go ahead. And, you know, with experience, that's a judgment call. But when you're starting off, you've really got to go through all of these things. That should I be doing this here? Should I be doing it at all? Is it safe for the patient? If you decide you can't get it all out and you want to send this away, think it is extremely important not to biopsy the lesion. The only time you want to biopsy a lesion is if you think it's cancer. You never want to biopsy a polyp. We have an absolute epidemic of people biopsying polyps in South Africa, and I'm sure it's around the world. You need to remove polyps. They are precancerous lesions. They must be removed in their entirety. Biopsying them just tells you it's a precancerous lesion that needs to be removed in its entirety. But what it also does, it makes it much more difficult to remove it later on. So take photographs, ideally take videos. You can take excellent video just by using your cell phone and videoing the screen, or getting the endoscopy nurse to do it. And video gives us a much better idea of the size of the polyp in that than a static picture, but both are better than nothing. Don't attempt to lift it if you can. Sometimes the reason why you've abandoned it is it doesn't lift, fair enough. But if once you've lifted it, you create fibrosis. And once again, next time you come, your chance of being able to lift it is smaller. What you do need to do, unless it's in somewhere like the cecum with obvious landmarks, you know exactly where you are, you need to tattoo it, but you need to tattoo it 2 folds away, because we don't want that tattoo to seep in under the polyp, because the carbon in the tattoo is an irritant and it causes fibrosis once again. I'm briefly going to show a video which will hopefully work of just doing a fairly standard polypectomy. This was just one we did the other day, so it's not particularly brilliant or overly edited. I did shorten it slightly while we waited for needles, etc. But I'll try and talk you through some of it if things are working. So there you can see a polyp on a fold in a fairly awkward position. And when we put narrowband imaging on, this looks like a fairly benign adenomatous polyp. I would imagine it's got low-grade dysplasia only. Not a particularly worrying polyp. It's probably about 8 millimeters. I've now twisted the scope around. This is the same polyp, believe it or not. And to get, because where you want to keep the polyp is around about at 5 o'clock, because that's where your channel comes out. It's much easier to work lower down, although we struggled quite a lot trying to do this. And you'll note that I'm injecting on the oral side of the polyp to try and push it towards me. And there we go, we're raising a nice bleb. And you can actually, as you're raising the bleb, you can sort of push it in certain ways to try and, you know, if you push down, it makes the lift come towards you. You can push it away and you can try and control where the lift comes. We're actually using a lift solution, that's a gel on this one, which I was using for the first time, but didn't work as nicely as I would have liked. And it doesn't, what I found with these commercial gel solutions is they're not quite as dark blue as the lift solution we normally use, which I'll talk about a bit later. But so it doesn't delineate the polyp quite as nicely. See, now I've injected again on the anal side of the polyp to try and lift it and get, so we've got the polyp completely lifted off the muscularis, and taking this off is now going to be very safe. It's extremely unlikely that it's going to cause a perforation, because you've got it lifted at least 1 centimeter away. The lift solution we use normally just is a Voluven adrenaline solution with some methylene blue. And the adrenaline is there just to cause vasoconstriction, to stop it dissipating. I'm going to do this with a cold snare. Anything under 1 centimeter, we're quite happy with a cold snare. This isn't the ideal cold snare, which is normally a monofilament. This is just a hot snare without energy attached, and it doesn't work nearly as well, and it's not really ideal, but we've got to make do with what we have sometimes, as everyone on this continent knows. And there we've got the thing, bring it up and it'll suck it up. We've got a trap on the system, and if you're doing a flat polyp like this, you can suck almost all of them up. It's only polypoid polyps that you need a basket for. So that's kind of our standard polypectomy for anything under 1 centimeter. What's showing again? So I've just shown a couple of other pictures just of polyps briefly. So here we've got a polyp at the bottom, also a small polyp. That's the lift solution. We usually use much darker blue as methylene blue, and you can see this delineated very clearly, so you know you're going to be able to get it out. You know exactly where the polyp ends and starts when you do it, and that's the bed at the end of it all. We can do some quite substantial polyps. So this was referred as a cancer, but when we reviewed the MRI, we were fairly certain it wasn't, and that's it at the end. A kind of intermediate polyp, a little bit concerning when you've got a depressed area in the center here, because that might be an area of invasion, but we've got a very, very nice lift on it. And so then you know that there's no invasion there. And this was taken out because it was just 1.8 centimeters, I think, and we did a hot snare on that. It was in the rectum, came out very nicely. And then another patient I'd started over here, almost 50% circumferential lesion that came out, and this is 2.5, 3 hours of work, and left with a colon that looks like that at the end, with no recurrence at the end. So those are obviously more technical, left-sided lesion, but quite satisfying, much better than having a left hemicolectomy if you can avoid it. So just on the guidelines, these are the European Society of Gastroenterology guidelines. I'm just going to stick mostly to the top here. If you've got superficial colorectal neoplasia, so you don't think there's an invasion, if it's flat, so they say if it's less than 5 millimeters, they do cold snare, and then if it's 6 to 9 millimeters, they do cold snare. So I don't know why they have 2 blocks there, but what I would say is that if it's less than 3 millimeters, if you can get a biopsy forceps over it completely and you can take it off in one bite, I think it's acceptable to take it off with a biopsy forceps. We do not use or advocate hot biopsy forceps. They've gone out of vogue, not on the basis of much evidence, but that's certainly, there's a concern about transmural burns. For anything that's flat under 10 millimeters, I'm very happy to inject and do a cold snare. The trick is to use the smallest snare possible. We generally have the biggest snare possible because you can use it on everything. It's much more difficult to do a polypectomy with a bigger snare. You want the smallest snare that will get over that. The moment you're doing a flat, a lesion that's greater than 10 millimeters, that's flat, you're starting to get advanced, and then it's probably, you've got to be thinking, are you the person to do it? But if there's no invasion, you're going to be looking at doing hot snare polypectomy, possibly with a lift. And try not to do it piecemeal if you can, but you might need to do it piecemeal if it's even larger than that. If you've got a pedunculated lesion, or you're going to do a hot snare polypectomy almost always, because you usually have a vessel in the stalk, and you need the diathermy to control that. And the moment you start getting very big lesions, we're injecting. I have to say, I almost inject every polyp that I do. It just makes me feel safer. I think it dissipates the load of electricity when you're using it. So if I put energy on a polyp, I inject. But I think the moment you've got something that's a big lesion with a stalk greater than 10 millimeters, you need to be prepared to deal with bleeding afterwards. And we'll talk about that a little in a bit. So just talking of complications, if we look at the complications, the 2 major complications we're worried about is bleeding and perforation. And everyone knows you get bleeding when you take a polyp off, and everyone knows you can get perforation when you do it. But I don't think what everyone understands is you can also get bleeding late, and you can get perforation later, and you can get post-polypectomy syndrome. So I'm going to come back to all of those, but we just deal with them one at a time. First, regarding bleeding, in order to stop bleeding, you do have to be able to clot. And so I think you need to have a history of, is the patient taking anything that might affect their ability to clot? Aspirin, you can probably go ahead with most polypectomies apart from major ones. Clopidogrel, we're a lot more worried about. Warfarin, depending on the indication, I will either stop completely or bridge. And the oral anticoagulants, also depending on the indication, I will either stop or bridge. And I think, those, you can look at the international guidelines, but you need to have a working knowledge of what to do with these lesions, especially with these oral anticoagulants and clopidogrel becoming more and more available. And I think, often it needs a discussion with the physician, what's the risk of doing the procedure versus the risk of stopping, and can be quite a complex decision. So if we talk of bleeding, how do we identify patients at high risk of immediate bleeding? So clearly a stalked polyp has got a greater chance of bleeding because it's got a vessel in it, and lesions on the right side tend to bleed more, and hypertensives tend to bleed a little bit more. Delayed bleeding is essentially thought to be caused by using excessive electric cauteries. Essentially, you get an eschar from the burn, and that burn then sloughs off at a later stage, and you get bleeding from it. So the bleeding can sort of happen at 7 to 10 days. So using lots of coagulation diathermy, or the blue button if you use an IRBI, can actually, although it solves your bleeding problem now while the patient's in front of you, you may get bleeding later. I have to say it's not something we see a lot of, but we use very low settings of diathermy, and I'm not very scared of bleeding in front of me. You can almost always, with modern techniques, stop that bleeding, but delayed bleeding, especially if you've got poor access back into hospital, is something that concerns us a lot. When we're talking about bleeding, I think it's just important to just discuss the difference between lift solution, tamponade solution, and tattoo, because there's a lot of confusion about them. So this is lift solution. This is how we do it. It's essentially 1 amp of methylene blue, 1 amp of adrenaline, 500 mils of Voluven. We use it to lift the polyp off the muscularis, delineates the polyp margin. The adrenaline stops the liquid dissipating. That's why we use Voluven as well. It dissipates more slowly. And so the adrenaline really maintains the lift. It's not really to stop bleeding. It's a very low dose. It's not a tamponade solution. And the blueness is temporary. It's completely absorbed. And if you use a lot of it in a complex EMR, it'll actually turn the patient's urine green, which they phone you about, quite alarmed about. Don't confuse this with spot, which is essentially Indian ink. It's a carbon-based tattoo, and it is permanent. It is used to tattoo where a cancer is if you're going to do laparoscopic surgery, or tattoo where a polyp is if you want to come back and see where it is. If you want to tamponade something, we just use the same solution as people doing, as you do for injecting an ulcer. That's 1 amp of adrenaline in 9 mils of saline, and you use it to inject as close to the bleeding as possible. Just remember, when you've done a polypectomy, if you use tamponade solution, especially for a flat polyp that's bleeding, you'll often see the blood vessel stays here and the lift comes above it. And so you have this bleeding vessel that you could see beautifully and place a clip on. You tamponade it because you've got it quick and easy at hand. And now you're trying to tamponade, now you're trying to clip a vessel afterwards that's at the bottom of a pit. So I generally, if I'm going to use a clip, I use a clip. I don't use adrenaline. Usually I use adrenaline if it's a very minor bleed, a little bit of an ooze that I'm slightly worried about. And honestly, to be honest, probably doesn't need anything. So these are the things we can use to stop bleeding. So over here, we've got a needle, and obviously that's for injecting tamponade with adrenaline. These resolution clips, or various brands of clips, and they're very useful, but they're a lot more difficult to apply than people realize. And often what we see is I get called and the patient's got 5 resolution clips on, and it's now completely impossible to get to where the bleeding vessel. You have to grab the vessel. Closing mucosa over a bleeding vessel, I don't think works particularly well at all. So I spend a lot of time taking these off, but probably the most important thing that you need is a washer. So scopes are quite expensive, and most of us use a scope and inject down the scope, but a foot washer, which costs about 40,000 Rand, which compared to the price of a scope is almost nothing, is a fantastic device. And when you've got bleeding, using a foot washer, this gives you large volumes of water to keep it clean, see what you're doing, get the clip, apply it accurately to the vessel to try and stop it. If you've got a minor ooze when you've done EMR, you can use APC if you want. And the other thing that I have used from time, which is a good sort of fix it if you don't have much equipment, is to take your snare, connect it to the diathermy, just extend the tip of it out a little bit and use it almost like a spot welder with a cheap band APC. Look, you can perforate with that quite easily, but if you're in a bind and you want to stop some bleeding, that sometimes just does get you out of it. And then on the far right here, we've got the Ovesco clip. That's the sort of nuclear solution, I think. If you've got a big polyp with a stalk that's bleeding a lot and nothing else works, by the time I come, I usually try, everyone's tried everything else. I go in with a Ovesco clip. I use the actual hood of the clip to knock off the clips and then just apply that. And it's very effective at stopping bleeding, and you don't have to be that accurate with it. There are some complications described with Ovesco clips, and they do stay there for a very long time, if not forever. They have been known to erode through things, but I find if you're in proper trouble with arterial bleeding, Ovesco clips are a lifesaver. So I think that any GI suite should have 3 resolution clips in the room, injection needle available for tamponade, and an Ovesco clip available. But the time to learn how to use an Ovesco clip is not the first time you see bleeding. It's a little bit of a nuanced thing, and you need to have done it a couple of times to be good at it. Okay, delayed bleeding, as I said earlier, is thought to be due to Eschar sloughing off 1 to 2 weeks post-polypectomy. It's more diathermy associated with more Eschar. Usually it resolves on its own, occasionally needing a blood transfusion. But I've never had to go in on a delayed bleed and stop it. So onto perforation. The first thing to do is to identify the fact that you've got an acute perforation. So one of the more subtle signs of acute perforation is when you're suddenly struggling to blow up the colon. It's collapsing all the time. If you've just done a big polypectomy and the colon's collapsing all the time and it wasn't earlier, it's probably because you're blowing up the peritoneal cavity. Obviously, if you see the peritoneal cavity, that's fairly obvious for most people, but sometimes you won't see the peritoneal cavity. You'll just see a sort of stranding tissue and you're actually in the retroperitoneum. I've seen that, someone just driving straight through a retroperitoneal diverticulum. And if you see that, you can close it and deal with it endoscopically, most likely. Okay. Immediate post-operative pain always needs to worry you. And if you've got a patient in pain, a bit of buscopan, a bit of analgesia, reassess, and if necessary, admit potentially a CT scan if you're really concerned. We've had patients with a tension pneumoperitoneum just after a stent that was placed incorrectly and had to be deflated as an emergency in the rooms. It's unusual, but have a look at the abdomen. If it's massively blown up and you've been blowing CO2 and air into it for the last half an hour, that can certainly cause blood pressure to drop. The other slightly more subtle sign as well, you're coming back and at the recto-sigmoid junction, you suddenly see a whole lot of blood. Remember, you can perforate. You don't always perforate the colon with the tip of the scope. You can perforate it with the elbow of the scope. And the classic position is ripping the sigmoid off the rectum, creating a tear there. So unexplained bleeding, just consider perforation. We look at the management of acute perforation. I think if you're in diagnostic doubt, you should do a CT scan. Just be careful. I have been caught after a difficult polypectomy. We saw some air bubbles outside the cecum, went and did a laparoscopy, and there was absolutely nothing to see. In retrospect, what we'd done is when we were trying to inject our lift solution, the needle wasn't primed, and we'd injected a little bit of air into the peritoneal cavity, and that was the cause of the irritation and the pain. But in the end, if you've got extramural air, you need to be very careful if you're going to treat that conservatively. There's a role for treating perfs conservatively, but one just needs to be cautious. So generally, CT scan is going to tell you if you've got an obvious perf. There is a role, so speaking of conservative management, I mean, not all perfs need to be treated with surgery, but if you've got a free peritoneal perf or there's large amounts of intraperitoneal air, you're going to be safer managing that surgically. Endoscopic management, if you see at the time that you've perfed or you're worried about perforating, you can use a resolution clip to try and close it, or an Ovesco clip. There's a very nice grasper that Ovesco has that does that and that. So you can grab the one end with that, grab the other end with that, pull it in and place the Ovesco over it. Clearly the disadvantage with the Ovesco is you've got to come out and go back in again. But certainly you can manage perforations full thickness, intraperitoneal perforation conservatively. Remember, you've got a prepped bowel in the right patient. It can work and is well described. If you're going to do an operation, you need to decide, are you just going to suture the defect, which can often be done laparoscopically, or is there residual polyp, or are you worried that it's a cancer and do you need to do a resection and deal with all the pathology at the same time? Delayed perfs, I think you can use, clearly we'll either need antibiotics, a percutaneous drain if there's an abscess, or if they come in with an acute abdomen, you'll need a surgery, but the diagnosis is almost always made with a CT scan. It's a delayed perf. I think if you see this sign, which is called the target sign at the time of polypectomy, what's happening here is you've got mucosa on the outside, then submucosa that's gone blue, and the inner ring of white there is the muscularis that's burnt white, and then you've got more adventitial tissue on the outside, and this is almost a full thickness burn that you've got. So the chance of perforation here is quite significant. Certainly if I saw a target sign, you would close the muscularis at the very least with resolution clips, or through the scope clips, or potentially close the whole defect with an Avesco if you need to. If you're not going to do either of that, you need to watch this patient very, very closely. These are the kind of patients that develop post-polypectomy syndrome. So essentially, post-polypectomy syndrome is someone who, for all intents and purposes, presents with a perf, abdominal pain, fever, raised inflammatory markers. There is no overt perforation on CT scan. And the mechanism is thought to be a transmural burn, causing inflammation on the peritoneal surface of the bowel, which causes irritation and pain, but there isn't actually a full perforation. You'll often see nothing on CT scan or just inflammatory stranding. And mostly these patients will settle on antibiotics, but certainly need admission and abdominal observation to make sure that it doesn't develop into a full thickness perf. Remember, this syndrome usually occurs a couple of days later. It's not immediate. I've certainly admitted a couple of patients after big polypectomies 2 or 3 days later, and they've settled down with time. So I think in conclusion, probably overstayed my welcome, one needs to decide, does it need to be removed? And just remember, hypoplastic polyps in the rectus sigmoid junction do not need to be removed. You just need to be confident it's a hypoplastic polyp. You need to decide, can you remove it safely and completely? And in order to do that, you need is it a cancer? In which case you're not going to be able to remove it completely. And can you get it out? Are you the person to get it out? Please biopsy cancers by all means, but do not biopsy polyps. Clearly there's a group of patients where you're in between and you're not sure, but flat lesions, if you biopsy a flat lesion, the person is going to end up probably having surgery for even a relatively small polyp because it won't lift later. Immediate bleeding can almost always be controlled, and perforation really is a killer, and it is really not acceptable as a complication, I think. While, as a surgeon, we all have complications. Unless you're people that do lots of large, big polypectomies may have the odd perforation, but you shouldn't be having perforations at polypectomy time, unless I think as a routine, for routine polypectomy, there really shouldn't be perforations. You've made an error. That's all I've got to say, so I'll stop sharing now. My screen will go blank for a little bit.
Hey, thank you, Adam, for a very nice, complete discussion on the topic. I see there's one question in the group, and that is from Sami Budabus. For cold snare EMR, on which criteria do you decide to inject or not? And if any sort of aspects like size should be considered?
So basically, I always inject even for small polyps for doing cold snare, because we don't have easy access to very small cold snares. If you want to do a small polyp with a cold snare, if it's flat, it's quite difficult to do with a bigger snare. So you need a really small snare. It's quite difficult to get small snares. You need the under 10 millimeter snares. So we tend to lift almost everything, but you can just judge it. If you think you can get it off easily with your snare that you've got, I'm perfectly happy for that. Obviously there's a cost involved in lifting and using a needle every time, So, that is a downside. And I mean, the reality is that a lift and snare makes a polypectomy very expensive, whereas, the good old hot biopsy that was probably reused 10 times is a lot cheaper. But, there's the concern that one perforation makes that a lot more expensive.
Thanks. And then just another question, are there any instances when you would consider prophylactic antibiotics when performing a polypectomy?
Not really. I think if a patient's maybe profoundly immune compromised, but as long as you're just above the muscularis, there's almost no concerns with infection. So I don't give antibiotics. I'm sure there's a situation where one might be tempted to, but not routinely. No. I don't also want to mask things. I mean, I want to know if the patients, I want the patient to stay in hospital if they're going to be on antibiotics for something. So I haven't given ever prophylactic antibiotics.
Okay, thanks. And just one more question. Obviously, this was on polypectomy, but I noticed that large rectal lesion you took out. Where do you think in our setting does ESD fit in for these large lesions?
Well, I think, the advantage of ESD over EMR is you're one layer deeper. And so if you've got an early cancer, and I didn't go into the European guidelines, they're using ESD for just early cancers, which they're identifying for using QDO essentially. But clearly the very, very large lesions, look, there's an advantage. The advantage of ESD is that you're not getting a piecemeal resection, you're getting one piece. And I mean, the schools of thought, the people that do ESD get out one piece, it takes quite a lot longer, but you can take very big lesions in a piecemeal EMR. And, if you're convinced, which you usually can be just by looking at it, that's a benign lesion, I'm not sure that the EMR is very safe. ESD, I think, has got a slightly higher perforation rate, but there are certainly very, very big lesions in the rectum that people with ESD can take out that you can't do with EMR. But I think for what most people do, you can do an awful lot with EMR, and ESD at significant cost. So, but I've seen pictures of people clearing the cecum of an entire polyp with ESD. I mean, what the Japanese can do with ESD is spectacular, but I certainly can't do anything like that with anything, not even with open surgery.
Thanks. I see Msheko's got a question there. Sandy, do we have time to take it?
Yeah, I think so. Seriously, there's a few questions there that are quite interesting. The one about competency of polypectomies amongst trainees, and maybe I can say a few words about that sort of assessment. Adam, do you want to handle that one? How do you assess competency for polypectomies? Obviously, we're focused on actual diagnostic colonoscopy, and we've got lots of key performance indicators for that. But how do you assess competency at polypectomies?
I mean, I think there are a couple of steps that you've got to do. But the first thing, what we're just looking at logbooks and minimum criteria for logbooks for the colorectal certificate, and what we want to get as a minimum criteria is just supervised polypectomy to start off with. So the fact that you're not just doing it on your own and watching a YouTube video, I think having supervision there. But one can take it as far as you need to. I mean, learning to inject and lift is a skill, and it needs to be taught, and it needs to be done proficiently. But you can't hope to do polypectomy before you're managing the scope and extremely well. So polypectomy comes at the end of being competent at colonoscopy, because in order to do polypectomy well, you need tip control, and in order to have tip control, you need a straight scope, and to have a straight scope, you need to know how to do a very good colonoscopy. So, I think that while lots of people do polypectomies, I think that it's not something we do very well, and it's not something we supervise very well. And the number of people in private practice in South Africa biopsying polyps yearly is quite remarkable. So, but I do think it's something that comes at the end of training colonoscopy. If you're still learning to control the scope, you can't hope to be doing polypectomies. So we've put in a minimum criteria of 5 supervised polypectomies as our kind of entry point for the colorectal certificate, with a target of reaching 25 supervised polypectomies. But,
I must admit, if I can just say a couple of things. I mean, the JAG do have criteria, and they assess polypectomies as an individual item. they don't assess it as part of colonoscopy. So it is a separate assessment if you want to move that in that direction. And I think the numbers, again, depend on the complexity. But if I can take you back to what we found at Grooterscure, is that over 80% of the polyps that we see are under a centimeter, and most of them are under 6 millimeters. So these are polyps that I think we should be teaching individuals to remove. So one of the other problems is how frequently we do actually see these, and that depends on your practice to some extent. If you're practicing on Africans in an African population, you're going to see fewer polyps in the state sector, at least, maybe not in the private sector. So I think if I have any words I'd like to say to the trainees is try and don't take on things that are bigger than a centimeter. And when you take 5 sounds a bit not enough, not too few for me, but you should try and aim to have at least 10 polypectomies supervised. And as Adam says, if you can't get it to 5 o'clock, it gets very difficult to take off even the smallest polyp. So my words, try not to do anything bigger than a centimeter and send them to individuals like Adam who are doing them. I do colonoscopies at Victoria. I sent him one in the cecum that I didn't fancy at all. And I was very pleased that I'd done that. So again, if you're not doing large polypectomies in a setting where you're doing them more frequently, I think you should try and find someone in your environment who is doing just that. Thanks. Sorry, Ed.
Oh, thank you. Then there was just a second question that I also wanted about. The Australians are big on this margin attenuation with coagulation after you've done the resection. It's also a question that was posed by Vikash Lala. What do you think about that? Because I think they've done randomized trials that show the benefit. Yeah,
there is randomized trials. The problem is you do that diathermic coagulation, it's quite vicious. And, you know, that was all done in expert units. I have done it. I've spoken to people in the UK about it, and they've quite very slick colonoscopists, and they're quite hesitant about it. But the data around it that the Australians have produced is very good, and it certainly does seem to reduce recurrence. And I do know that we have quite a significant recurrence of things. I have to say I don't do it routinely, but I do it on certain cases. But I'm just a little bit concerned about, you know, translating something from another healthcare system where access back, you know, the kind of perforation you're going to have from doing that. If you do have a perforation, it's going to be a delayed perf. And that worries me in my environment. I'm terrified of delayed perforations because the first time we'll know about it is septic shock. So we don't do it routinely, but I have done it on occasion. And when I'm doing it, I sort of always quite keen to admit the patient for a day, which doesn't make any sense because the perforation will probably happen in 3 days, but it makes me feel better. But I mean, the evidence is quite impressive.
And I think there's finally 2 brief sort of answers on the right colon, right-sided defects. Do you close with clips?
So there was a fad of closing with clips. The evidence for closing with clips is very, I mean, it's actually non-existent. It's a perceived increased risk of bleeding, in fact, not to stop perforations. And we did it. I mean, it looks very pretty afterwards. You can really close quite large defects just by going to the corners, closing a bit, then again and again. But clips are jolly expensive. And, you know, you've often got to use 5 or 6 clips, and you usually get 2 of them in the wrong place. So that's 8 clips. And by the time you spend 20 grand on clips on an evidence base of almost 0, apart from feeling quite pleased with yourself, I'm not sure you've done any real benefit. So I've stopped using clips unless there's a major problem or I've got a particular concern.
Okay, and then just last, retroflexion in the right colon. You always do it?
No, we don't routinely do it. But I sometimes do it when I'm trying to do a complex polyp in the right colon. It's the only time I do it. It's certainly not part of any of the guidelines I've seen. I know the Americans prefer it, but they're often doing it under propofol. Retroflexion in the right colon can be a bit uncomfortable. We retroflex routinely in the rectum only, which is shown to have a benefit.
No, thanks. There's a question on gastric polypectomy that I'll quickly answer. And so if you've done gastric polypectomy, I think it's good to give PPIs. You create an ulcer, and it's been shown that raising the pH does stabilize the clot if there's a clot forming on it. Thanks. I think that's it, Sandy. We can probably move on.
Yes, yes, I think so. So next up is Professor Shetshedi, who's taken over an interest in H. pylori in its various guises. And one of the I'm sure she's going to inform you about how what she's up to, and I'm a little bit involved with what she's doing. And really, this is sort of a plea for us to get more information about H. pylori. Over to you, Michiko.
Thank you so much, Professor Thompson, and thanks for allowing me to present. I just asked for a few minutes just to tell you about the project that we're doing, and just to request for your support in this venture. So my topic is not exhaustive topic on H. pylori, not at all. What I really want to do is just to talk about the current guidelines for HP management, to what effect do they work for us, and to what extent do we actually need our own data. And then I will review just some relevant studies that have been published in Africa in this regard. And then really my talk is about the challenges and how we can move forward in trying to address H. pylori in sub-Saharan Africa. Because as we know, it's it's endemic. All of you know this, the treatment of H. pylori. Effectively, the first line is triple therapy, a clarithromycin-based regimen. For various reasons, you may or may not have access to that. And that has been shown in many, many studies to be probably the most efficacious first line. If you don't have that, then you can use a bismuth quadruple therapy. And again, some people don't have bismuth or concomitant therapy. And clarithromycin-based therapy really works when the prevalence of clarithromycin resistance is known and it's less than 15%. And then if the patient recurs with the symptomatology or positive H. pylori tests, then you use a second line regimen. And basically you want to use antibiotics that you didn't use the first time around. So you can use a levofloxacin-based therapy, a triple or quadruple, or you can use bismuth if you hadn't used it in the first instance. And then importantly, for third line therapy, in those that are resistant to your initial therapies, the guidelines suggest that this must be guided by antimicrobial sensitivity testing, but alas, this is not available in our setting. And of course, again, you can use antibiotics that you had not previously used, or then you can go to a rifabutin-based regimen. And what I really want to talk about is that, yes, we do have the Maastricht 5 guidelines for managing H. pylori, and what there's a quite need for are guidelines in our own setting. And I've chosen statements from this guideline to show you why we need our own data and why we need our own guidelines. These statements all refer to issues of resistance. And the first one we know is that H. pylori resistance to antibiotics, the rates are increasing even now in most parts of the world. We know that resistance to clarithromycin or to metronidazole undercuts any of the therapies that you might have at your disposal. We know that you need AST in order to be able to guide your therapy where there's resistance. And I'm not going to go through all of these statements, but they all speak to needing to know the degree of resistance in your area. And these are region specific. They're not the same throughout Africa, as I'll show you. So that's the first problem that we have, that we don't know what our resistance rates are. We don't know what they are in different regions. And the medications that we have to use are show resistant strains. Other challenges with the guideline is that you need to understand the eradication rates and the cure rates. And in many instances, we don't check for this, either because we don't have the tools to check, or we just have too many patients that we're seeing. The issue of treatment duration, so the guidelines say you should use 14 days, unless you can show in your population that a 7 or 10-day regimen is equally effective. So you need to be able to do tests to know what is going on in your population. And then I've spoken earlier about whether you have bismuth available or not, because that is a go-to second-line regimen if you hadn't used it the first time around, or concomitant therapy, which implies an increasing number of antibiotics, and that might have cost implications for resource-poor settings. Here I'm just highlighting studies that have been done in Africa. So it's not that there is no data. The data is sparse, but at least it does give us an indication that perhaps our epidemiology in terms of H. pylori here might be slightly different. Again, speaking to the issue of us really needing to write up our own guidelines. So here in Tunisia, there was a study which was using a clarithromycin-based therapy and comparing it to metronidazole-based therapy. And as can be expected, clarithromycin therapy was superior to metronidazole-based therapy. In Morocco, they did a trial which again showed that clarithromycin therapy was good. However, given the eradication rates that were low, there was a suggestion that the resistance rates to clarithromycin might be high. So this is that context-specific, regional-specific, population-based differences that I was talking about. It's not going to be the same throughout all of sub-Saharan Africa. The issue of duration was tested in a study here from Nigeria. Here they compared a 7-day to a 10-day regimen. Again, it was a clarithromycin backbone, and there was no difference in the duration and in the efficacy of the regimen for 7 versus 10 days. And this is a different study done in Kenya. And here again, when they compared a 7-day regimen to a 14-day regimen, there was no difference. So these two studies, although they're patchy, might suggest that perhaps in our population, a 7-day regimen may work, but we don't know that yet. We don't know that yet. We don't have enough studies to tell us that. So we're stuck with going with the suggested 14-day therapy, which may be costly, which may promote resistance, and which our patients may not necessarily tolerate. This is a nice study that was done by Jaka, published in 2018, and essentially she showed the resistance rates throughout Africa, and I've tabulated it here in a graph, and essentially this suggests that none of the agents that we use are eligible, because the resistance rates, even for the fluoroquinones, is 17% all the way to metronidazole, which is about 75%. So just looking at this graph, it suggests that really the drugs that we are using are not effective in treating H. pylori, and therefore we can anticipate that the eradication rates are very high and that we are failing. Excuse me. So just with those few short slides, I thought we should highlight the challenges that we've had, and I've tried to allude to some of them, and really where we can go with this. So the strengths are that really we are unique in Africa in terms of our population, the fact that we acquire H. pylori at a young age, so maybe that has benefits in terms of a reduced or a Th2 type response. And maybe this explains why our risk of progression to cancer is not as high as is seen elsewhere. There are many GIT societies within sub-Saharan Africa. I think this is a plus, and I think we need to connect and work with each other and collaborate to try and get our own data, to work together in order to come up with guidelines that make sense in our context. I've shown you that there is some data. I only showed you selected studies, but there is some other data that's available. Ethiopia publishes quite a bit on this. And then as I've shown you, that it may be that the 7-day regimen in our setting is useful. The weaknesses is that yes, there's data, but it is scanty. It is differential depending on the region. There's high resistance rates, as I've shown you. There's issues of affordability of drugs, availability of drugs. There's no question that there are heterogeneous practices. So some people believe that if you find H. pylori, that you should treat it even in a patient who's asymptomatic. And then there are others who do not believe that H. pylori in fact causes gastritis or inflammation, and therefore they don't treat it. So across the board, I think even we as medical practitioners are doing different things. We have a systemic issue of inadequate health systems across Africa. And I think also another problem is that we're concentrating solely on therapy. We haven't even begun to think about how we can prevent this infection. Issues of vaccine development, we haven't even gotten there yet. The threats, the ever-present threats of lack of resources and having to direct our resources to other more pressing conditions and illnesses. I've spoken about inadequate health systems. I've spoken about the difference in the ideological understanding of this disease and what it does, and also the issue of working in silos rather than collaborating. But the opportunities are there, they're immense. What we can do is to start with reviewing existing data. At the moment, I'm involved in a group where we are now undergoing the Delphi process and examining statements and wanting to come up with statements so that we can write the guideline that is specific for sub-Saharan Africa. we need to create our own data so we can understand what's going on the ground. We need to create registries, share information so that we can understand globally across the continent what our epidemiology of H. pylori is. This may help us to unravel the African enigma. Does it even exist? What are the factors that promote the African enigma if it exists? And then I think in our context, the role of the microbiome, is it protective? Would using probiotics be more efficacious than using the drugs which show resistant strains? So to this end, as I've said, I'm part of the African Helicobacter and Microbiota Study Group. And really the aim of this group is to provide a platform for consolidated activities for all of H. pylori work. And we want to channel this work through the foundation. And so we are at the process of really getting all the stakeholders involved. I've spoken about working on coming up with a Maastricht 5-like African guideline, and that's what we're busy with. And the other thing that we've done, which is the last point in the slide, is that we've created a survey. The survey is to try and understand the practices of H. pylori amongst all the clinicians in South Africa. Actually, it's a continent-wide survey, but for us in South Africa, we would like all of you and any other medical practitioner that you know who manages patients with H. pylori to please fill it in. I did it this morning. It's an online form. It takes 3 minutes. It really is not long. And we need to collect this data. So we're asking about the practices, the access to medication, and access to endoscopy service, biopsy, laboratory, and pathological services, all of that, so that by understanding what was happening regionally, we can really start to see, A, what studies we need to perform, and how we can collate this data to input into this guideline that we're coming up with. I've asked the president of SAGES, and this survey is going to be distributed via SAGES. So please look out for it, and please do fill it in. As I say, it's pretty quick. So just to conclude, I just wanted to say that existing guidelines are good. We have them, they do inform our practice, and they are very useful and helpful. They do highlight, however, the need for regional data, because as I say, the regions do differ, but they also do highlight the challenges in applying all of the guidelines in the Maastricht, for instance, in our own context. Some of the stuff doesn't fit. It's not fit for purpose. African data does exist, but as I say, it's scanty and we need more. We need a lot more of this. And I just feel that we can adopt more context-specific approaches, whether diagnostic or therapeutic or preventative, by collaborating and sharing and creating knowledge. So I had asked Prof. T for 5-10 minutes because I just wanted to appeal that we need to work together on this. And again, just to ask for your support in filling in the survey and distributing it to anyone that you know who may be managing this condition. Thank you so much. I really appreciate the opportunity.
Thanks very much, Mashiko. Yeah, I think we've all been dabbling in this field for a long time, and what happens on the ground and what is recommended even by the WGO are two different sets of, certainly in the role of therapy. And I think you've highlighted those aspects beautifully in the way you've presented the data. So I'm happy to take any questions for Mashiko, but I think the first thing is to get some data, and this survey is a start regarding the practice. And I'm sure anybody who's interested in joining the group is more than welcome. I don't think it's an exclusive group. And I do hope that this is a platform also that not only can get information from South Africa, but this platform will allow us to get information from Sub-Saharan Africa. And without exception, Nigeria and Ethiopia seem to be the only places, maybe Kenya, otherwise it's on the Mediterranean coast where we have some information.
I forgot to add that it does have ethics approval. And it has ethics approval in most of the countries that we're collaborating with, if anybody's concerned about it.
Thanks. Chris?
So Sandy, if I just may say, and Mashiko, I think we must send this questionnaire through the GASA network, which Cheryl has. You won't reach this audience through SAGES, I don't think. So look out for the GASA. We've got a dedicated GASA website, not website, email distribution, which Cheryl will control. So anything that you want, and this is an advertisement for anyone who wants to inform all our Sub-Saharan colleagues of what you're doing, or if you want to advertise the meeting, use this portal through Cheryl, the GASA portal through Cheryl. So we'll distribute it, Masheka, through the GASA distribution as well.
Thank you very much. Do we have, I'm not sure if there's anything in the chat.
And no, Sandy, there's nothing in the chat.
Yeah. So I think we've had a very informative session. We've started the year. I'd like to mention that there are a couple of new items that have been added to the Gecko platform, if you will. And that is that we're going to have a radiology Gecko next week. And this is based on an interaction that we had at the SPEAR Fellows Weekend. And we hope to take this radiology, especially focusing on GI problems through the platform. And also, we really recognize now that ultrasound is becoming part of GI practice and part of clinical practice. It's just an extension of your hands. And so there will also be a focus on hocus pocus, or point of care ultrasound in the hands of gastroenterologists. So please watch this space. Please address and register when you see these adverts coming from Gecko. And we really hope that we can provide a useful educational platform for you all. Again, those in countries from elsewhere, we're always looking for you to provide us with cases so that we can discuss those cases. No matter how mundane you feel they are, I think it's very wise of you to try and keep in touch with us, the individuals who are running the Geckos, so that we can integrate what you want into the Geckos. So on that note, I'd like just to say thank you again to New Mexico and to India, and thank everyone, and particularly the talkers. And I see Christian Chuson there from Cameroon. So welcome again, Christian. It's good to see you, and hopefully you're enjoying these interludes that we provide on a Wednesday afternoon.
Okay, good evening. Good evening.
Thank you. Okay, bye-bye. I think meeting's ended, officially closed. Thanks again.